I do see potentially a question here. I think maybe Dave is here. Dave, do you have a question?
I do. Question. I have the drop foot. I didn't have a
Sure.
stroke. I didn't have any type of anything like that. I was getting a hip replacement revision, and when I woke up, I didn't have any feeling or movement all the way down the extremity of my right leg. I went through countless physical therapies and all kinds of stuff, and I even tried the thing they had where they put it was like I guess like a 10 unit that made your foot move, and that was when I first. It was like been 5 years now for me. Um, and I, they just everybody's just like, well, we're just basically cheering for you now. We're praying for you, kid.
Sure. Sure.
Um, this apparatus you have, I know, I don't know if there's like I've been reading. Is there a cure for drop foot? They're talking about like I know with mine they had to do screws and all kinds of stuff with the last hip replacement revision. And one doctor said, well, it's a centimeter from the nerve. The other one said that it's impinged on the nerve. I'm like, come on, man. And the nerves only regenerate a half a millimeter a day. So, I'm sitting here with my calculations trying to go through the stuff to try to see. And man, you think this thing would help me? Because it's like I wear the AFO, I wear anterior AFO. It
Hmm.
doesn't move. I have a lot of pain. The shoes, I can only wear certain size shoe kind of shoes, and I'll be looking for any kind of help. You think that it would help me?
Okay. So let's chat about a couple things. So you said you had um, a hip replacement, or
Hip,
was it hip revision?
hip revision. Yep.
Hip revision. Did you have initially a hip replacement and then there was a revision from that, or was it a post fracture revision?
No, they said I wore it out. Well, this one,
Okay.
so I had one in the beginning. I'm gonna tell you my
Okay.
history. The first one, I'm from Ohio. We have the little black ice. I live in Georgia, but I'm from Ohio. The little three-step house. I slipped off there like Fred Flintstone. Bow, fractured it. Arthritis set in. The other one got jealous, so they had to do the left one. And then the
Okay.
right one was, oh, you trying to take my place? So it came back and they had to do a revision on that one. But when I got there, it was a new doctor. And I was like, no. I was like, please don't give me this new doctor. So the new doctor, young, they say he's a whiz kid. He comes and a month and a half later, it slides out. I'm like, I literally hear it
Mm,
go, and I'm like, so something was happening with the pharmaceutical company and the hospital and the insurance company where I was supposed to get this piece designed to put in there. They put me in the MRI to design it, whatever, this, that, and the third. And they did it. But they would, for some reason, they wouldn't buy the piece. So one
mm.
day, because I'm a performer too. So I'm a bigger dude and I'm a performer as well. And so I would sit down, it would slide out, I would push it back in and just go. And one day I couldn't put any pressure on it. The
Hmm.
cup had turned all the way around to the
Sure.
back. And
Yeah.
then
Well,
to the
this is a
doctor.
tough one. Yeah, this is a tough one, Dave. I think because so what happens, I presume that you also had a nerve block at, after your surgery or during your surgery, they probably put a nerve block in.
Mm-hmm.
And if so, it could be one of two things. It could be actual damage from, I don't know if you guys know exactly how they do this, but when they actually, it's a bit disconcerting. But how they do a hip replacement is they will actually fully extend your or fully flex your hip
Right,
and externally rotate it and to dislocate it effectively because it has to be dislocated to be able to be replaced. It's a
right.
pretty ugly process, a pretty barbaric thing. But during that process, your joints are in very, very extreme ranges of motion. And when you put a joint on extreme range of motion, the nerves that go around that joint can be put on tension and they can be damaged. So
Mm.
in those cases, um, what most happens is you go through a process of peripheral nerve regeneration, and that can happen. Now, there's no definitive way to ensure that you'll have that regenerative process go into the right place. So you could certainly have regenerated nerves that make it back to the wrong area. So, for instance, if you had a nerve that was supposed to go to your muscle, your tibialis anterior muscle, there's no guarantee unless a neurosurgeon came in there and literally put those epinuria surgically back together. Sometimes they will also go and they'll innervate the skin. They'll go innervate different muscle groups, for instance. And if sometimes they won't even go into anything, they'll just go into a joint capsule and they'll create what's called a neuroma. They'll create a bundle of nerves and that will cause a bunch of pains. And those neuroma can be very, very painful. So peripheral nerve damage is something you don't really want to mess around with, if at all possible. And so it's going to be really hard for me to say, Dave, that there is a cure for this outside of that surgical sort of reattachment. And that generally happens at the time of injury or the time of surgery. The other thing that could be happening is if you did a peripheral nerve block, insofar as they would do like a femoral nerve block or an obturator nerve block to help prevent pain following injury, those themselves can also cause damage, just because they'll put the injection at or near the nerve, and that can cause physical disruptions. Those will not physically disrupt, like physically remove the nerve ends. And in that case, you can just get regeneration along the epineurium and you have an increased probability of success. I don't know specifically what your case is. You would probably have to know whether or not there was any electrical activity in that muscle to know whether or not we could have some sort of capacity to come back. So I don't know if you've had those tests done in terms of nerve conduction studies, but a nerve conduction study would be the kind of next best bet to see whether or not a program like this could actually help.
Right.
Because what needs to happen is we needed to know whether or not the sort of wires are intact for us to see if we can try to reorganize the wires. Otherwise, we won't know whether or not, if there's a full transection and the nerves are not actually attached to the muscle anymore, then we need to think about different strategies. Think about using exogenous forms of muscle contraction, something like an FES system, where you had a functional electrical stimulation system to help basically take over, because there isn't a capacity for an endogenous control. So without being able to know any more details, it's going to be really hard for me to know whether or not it would be a good fit.